All right, welcome everybody to our Making Digital Health Real seminar series. We are very pleased today to have Dr. Peter Steel speaking with us. And Peter's one of those rare people who combines clinical practice with research and quality improvement, but also has, I'd say quite a bit of technical knowledge, maybe not in the extent of being like a PhD in computer science, but he has an R01 from the NIH applying machine learning. So really one of those applied informaticists who's trying to create a learning health system in his area. And I thought that we had a lot to learn from what he's doing. And our Learning Health System Academy fellows who are in person today will be able to see an example of a really successful career that's being led by his passion to really improve the way that we care for patients. So I'll let Meg do the formal introduction of him.
Thanks, everybody. Thank you to those jumping online, and definitely thank you to those who have joined us in person today for Making Digital Health Real. I'd like to acknowledge the traditional owners of country that we are on today, which are the Wurundjeri people of the Kulin Nation, and pay respects to elders past, present and emerging, and acknowledge that sovereignty is never ceded. This morning, as Wendy has said, we're really fortunate to have Dr. Peter Steel join us all the way from US. And Peter Steel, like Wendy said, is a hybrid position, really, and he's complemented his clinical work really well with the research that is undertaken. He's an emergency physician and associate professor of clinical emergency medicine at Cornell University. And as current role as vice chair of clinical services, Peter oversees clinical services and leads collaborative, operational, quality, and patient safety initiatives at both Weill Cornell Medical Center and Lower Manhattan Hospital emergency departments. This morning, we're really fortunate to have Peter join us and give us an insight into the real first taste of a learning health system. Peter, I'd be delighted to hand over to you and let you take the ropes.
Well, thank you both for such a kind introduction. It's a real privilege to speak today for two main reasons. The University of Melbourne is my wife's alma mater, so I feel particularly privileged in that context. But also in speaking to Wendy about the Center for Digital Transformation, it feels like there's a really world-class opportunity here, not just to transform healthcare, but to, of course, transform the health of the people of Victoria. So I feel very privileged today. Thank you for the invitation. I'm going to move right into a little bit of context of my organization. So New York Presbyterian Health System is one of the nation's largest hospitals in the US. We're comprised of 8 main hospitals across New York, collaboratively led by 2 university-based medical schools. 4 of the hospitals are under the sphere of Weill Cornell Medical College, my home, and 4 under Columbia University. So combined, NYP Hospitals has over 3,000 hospital beds, 6,000 physicians, 35 plus employees, and over 2 million patient visits annually. In my current role, I have the privilege of leading a talented group of 15 or so clinical leaders across 2 of these hospitals. My team oversees the supervision of about 160 emergency medicine physicians, fellows, and residents who provide care for annually about 150,000 ED visits, but also 50,000 telehealth visits. And to support our learning health system paradigm, our team also includes 2 data analysts, 3 physicians who are board certified informaticists, and my PhD research partner. And what I'd like to emphasize today, the subheading of this presentation, if you will, is a vision of professional ambidexterity. This has been well described in the business world, but I think equally applies to learning health systems, where in one hand, we have the task of iterative expansion and improvement of informatics infrastructure, and then the thoughtful leveraging of this infrastructure to iteratively improve the care model, predominantly by both evaluating interventions and seeding patient outcomes. And then on the other hand of ambidexterity, in the setting of AI and telehealth, we must break new ground in healthcare and clinical innovation. And that's often in partnership with both industry and a diverse group of researchers. So I want to start with examples from the left side of the brain, building basic informatics infrastructure for systems of transparency and accountability. Also developing a growth mindset culture for interpreting data. and thus using data to support and evaluate management strategies and interventions. You know, last year, BMJ published a scoping review, which outlined the key elements of consensus from up to, I think it's 89 articles on the learning health system. And they described the following macro strategies that I like to think tracks with this left brain concept: an investment of data infrastructure, its integration into clinical workflows, and then this cultural shift to iterative knowledge growth. And so in my decade plus of experience as a leader, what has that meant to me? I would describe it in shorthand as turning on the lights and then taking advantage of the opportunities that follow, as well as managing those. Our strategy was to start small and build complexity in over time. And this is a really simple example of getting the right data to the right people at the right time. It's an automated Monday morning operations email to my physician and nursing leadership. It gives them last week's key operational performance metrics using the format and context that will best help them evaluate performance and drive improvement. This is a slightly different format. It's cookie cut from Tableau. We didn't build this from scratch. Using visuals to tell a story, but also granular data to inform actions in response to that story. These are heat maps, and this particular one is based on arrivals to the ED by hour and day of week. So the colors offer the story of the volume patterns, and the numbers in each block tell you exactly how many patients are arriving per hour. So my team can answer the question, how many physicians do we need at 11 a.m. on Monday, based on the past year's arrival data, to staff it to 3 patients per hour. And we've utilized many heat maps to inform optimal staffing decisions, as well as advocating for more external resources when needed. Like almost every contemporary health system, we have radiology dashboards. I'm sure the ED at the Royal Melbourne does too. And these offer insights into turnaround times for both study completion and study interpretation, which is key for emergency medicine throughput. Our collaboration with Cornell Radiology has been extremely strong for over a decade. In fact, year on year, their department surpasses the median targets we collaboratively set together. But yet we continue to hear complaints from frontline teams of long wait times for studies or the reads of those studies. And even in my own clinical experience, on almost every shift, I'd observe 1 to 2 cases of major delays. And looking around, other centers have used the Toyota lean methodology to systematically improve radiology throughput in hospitals and published that work, which we digested. But what we chose to do was overhaul our dashboards completely, disposing entirely of median reports and focusing on outliers. So we built outlier dashboards, and they report both the frequency of these outlier cases and when they are occurring. And you can see on the left side of the screen that most recently, Thursday has become an anomaly of outliers, and this warrants obviously more investigation. We also built in the capacity to drill down to an individual event level. On the bottom right, you can see a list of encounters. This allows like a root cause analysis of clusters of outliers, which can then inform subsequent corrective projects, which is perfectly aligned with Tashiono's concept of the lean process. In 2018, we required an interdepartmental Kaizen on hospital flow. We were having real problems with flow. And we brought together emergency medicine, internal medicine, other relevant stakeholders to generate consensus on what the flow bottlenecks were, and to subsequently develop projects to drive throughput efficiencies. One consensus was delays in the ED to inpatient admission process. Though not unexpectedly, we didn't initially arrive at a consensus on which team was responsible for this bottleneck. Fortunately, though, the multi-step admission process and each step's respective timeframes could be mapped out from data in the EHR. This enabled us to build consensus around which time periods were accountable to which team's activities, so we could turn on the lights, if you will, without controversy, and then evaluate which narratives from the Kaizen bore out in the data. So on the left of this dashboard, you'll see a series of data definitions, which essentially explain which team is responsible for which of the measured steps. And then we can create filters in the dashboard, as you can see on the far right, to narrow the scope of any particular examination to a team, a time of day, a time frame, and then later in this project, as it scaled, to different hospitals across our system. Based on feedback from that Kaizen, we also developed a standardized Epic electronic sign-out tool using smart phrase in Epic, which allowed ED providers to summarize each patient's ED care the results, the critical interventions from the encounter. And that helped facilitate a safer transfer of care to the inpatient team. To ensure this practice became hardwired into our ED culture, we built a dashboard to monitor the frequency of the smart phrase used by each provider. And with outlier providers, we engaged them in bidirectional feedback. So these mechanisms of transparency and accountability allow leaders implementing these changes to immediately track the impact and also, most importantly, the sustained in performance of whatever intervention we're launching. Another interesting theme that came out of the Kaizen was a concern about patients with complex medical, social, and psychological needs that would spend weeks admitted to the hospital, despite not having any acute medical condition that actually required inpatient management. So we did a preliminary analysis that demonstrated that that narrative was correct. In just 1 year, only 19 patients accounted for 1,300 bed days, which is a total of 1% of all hospital bed days for the entire hospital. So as you can imagine, this became a major project of interest for my team. We learned more about the patients with deep dives into their history during chart reviews in the EHR, and then subsequently developed a plan to improve their access to outpatient care. We also placed guardrails around the disposition decisions emergency physicians were making. And we wanted to also avoid duplicating evaluations over short timeframes. So how did we achieve this? We developed individualized management plans for each patient, and they were developed by a multidisciplinary care team. We invited social workers, care coordinators, psychiatrists sometimes, primary care, general internal medicine, and others to the table to build these care plans, whether they were then approved by leadership and entered into the EHR. We also developed EHR-based alerts that surfaced when these individual care plans, they surfaced the individual care plans the moment the patient arrived in the ED to guide the ED team's management plans. So following the launch of these two interventions, the longitudinal plans of care and the accompanying EHR alert, we measured to see if there was improvement in healthcare utilization in this very small cohort of super high users. And we saw a dramatic reduction in their ED utilization from, on average, 36 visits a year down to 12 visits a year. Acute hospital admissions went down from 17 to 3 admissions a year. And total bed days from an astounding 54 bed days on average a year to 5. So today's super high user dashboard allows us to monitor the healthcare utilization of these patients, those that have active care plans across our system, as well as screen for new super high users based on recent utilization patterns. On this screenshot that I've shown, we can see that there are 2 new high utilizers that have visited the ED based on the filter I put in up to 20 to 49 times over the past year, with between 10 to 19 admissions over the past year. I just added this screenshot today, so it looks like we have 2 more care plans to write. But like many of these dashboards, this project have now been scaled across the enterprise, which allows us for higher fidelity data because patients interact with different hospitals at different times. Going back to the BMJ summary, they write some interesting things about the model provider in the healthcare system, drawing your attention to skills to utilize the digital ecosystem, as well as fostering a self-reflective capacity in the workforce. Led by my director of informatics, Jean Scofie, we spent a year building an ED clinician feedback dashboard. This was designed to improve individual practice patterns, as well as increase accountability. We designed it specifically to be dynamic and interactive, and the goal there was to encourage providers to independently synthesize their data and enjoy using it, if you will. And it was also designed to be non-punitive, private feedback, although it did offer the context of their performance compared to other providers. We invited 10 frontline emergency physicians to join the design team, including these 2 energetic young guys. We wanted them to feel heard during the design process and share any concerns about the punitive culture of report cards from years past. We also wanted to understand the key levers of motivation, what would drive them to the dashboard, and hot button issues, what would turn them off. So in essence, this was a user-centered design process. One consensus from the work group was to use a box and whisker plot to represent the majority of the data. we felt it offered providers a sense of where they were compared to colleagues, but privately, and if they were above or below the median, by exactly how much. But this format wasn't as intuitive to read for all team members when we launched it. So Jean developed an educational module to go along with the dashboard to ensure our providers could accurately interpret the data and thus their own performance. This is an example of one of the dashboards. This view allowed providers to review their patient satisfaction scores, and they could filter it themselves across different age groups and timeframes to better understand their performance. This view allowed providers to review their utilization of certain resources. And the raw data alone was not accurate, so we had to correct for number of shifts worked and the types of patients that they saw. We also produced back-end views so that leaders could stay abreast of outlier providers. In this screenshot, those outlier providers are flagged in red. And these are some of the team members responsible for this amazing dashboard effort. And you may then reasonably ask, what is required of the non-building physician leader, in this case, me, while teams are doing the real work, hardwiring the health system with the necessary dashboard and metric reports to drive excellence. That's a great question, and my answer is, one, the leader should be developing a vision and strategy to ensure that the data drives process improvement, not just data for data's sake. It's also important the management team develops consensus on what the build prioritizations are, and that those prioritizations align with the strategies of both the organization and the individual departments you're working with. The leader should also anticipate managing interdepartmental collaboration in builds, also managing the informatics team's performance, including helping to address their challenges and their barriers, and also knowing when to push for iterative improvement along the way. I would say the fourth thing is also for the leader to, across the frontline providers and the junior management team, steward this scholarly, intellectually curious approach to data synthesis that follows. There can be a reaction in the setting of turning on the lights to low performance of a defensiveness. So I want to pivot now to talk about the right side of the brain role in ambidexterity, which is finding opportunities for scholarly innovation along the way. So going back to that ED pass note, the epic smart phrase we developed to standardize the admission process. Boy, so writing an admission note was a lot of extra work for our already busy ED providers. And while our note completion metrics look good, if you remember, we built a dashboard to see who was completing these notes. On doing individual chart reviews, the quality was slipping. And from my perspective, continuous manual chart reviews and downstream feedback to sustain high performance was not going to be the smart choice moving forward. So we've now partnered with a startup to generate automatic ED care summaries at the end of the ED encounter. This is using an encoder-decoder transformer LLM model. They're currently using BART, but there's plans to upgrade to Llama 2. Now, this startup has already published work in AMIA, good work, partnering with our neurology department at Cornell to develop inpatient core summaries. But in looking at that study, it demonstrated 62% of the automated summaries met the standard of care. And while they had promising ROUGE scores and it was impressive work, that wasn't implementation ready. So we want to help take the model past pure academia and create a more rigorous approach to develop and evaluate the model's performance with the goal of clinical implementation, not just publication. And so I'll describe this as an example of choosing a specific priority use case to partner with industry, and then investing in this mutually beneficial scholarly journey, but scholarly to develop a product that serves our clinical mission. So that journey also demands the development of regulation, including performance monitoring systems such as infrastructure to support continuous learning of the model or revalidation of the model. And of course, our FDA of the US has developed new regulatory constructs for AI-based medical interventions. But my sense is we're existing right on the frontier of healthcare technology integration here. And so many of these evaluation and implementation decisions will have to be made by us for the first time. And at NYP, I'm part of a predictive model work group led by Dr. Ashley Beasy that brings together a diverse group of stakeholders and experts such as myself and within the organization to help build consensus around these frontier decisions in scenarios where there isn't a best practice for the many models we currently have in pre-implementation stage. So moving on to what the learning health system requires from its patients, I'd like to draw your attention to BMJ's the ability for patients to interact with the technology. In 2019, just pre-COVID, the ED was struggling with patient experience scores. I did a detailed review of the pre-existing data, and it looked like the discharge process, or how we closed the encounter with patients, was a major part of that story. In response, we redesigned the discharge process completely, moving away from the multiple sheets of paper that explained only some of what patients needed to know about their visit. These on the screen are photos of generic paper discharge instructions for a patient with chest pain at the time. There's no information on these papers about the nuances of that specific patient's encounter, nor their test results, nor what medications they were prescribed, etc. So we designed and launched an online platform, giving patients secure access to individualized ED discharge instructions, plus their laboratory and diagnostic test results, plus details on new medications, follow-up instructions, and return precautions, everything they needed, and that they could access this through their smartphone. A link to this platform was texted to the patients 3 times, initially at time of discharge to ensure they could access it, as well as 2 more times after discharge as reminders. So leveraging cell phones was a huge success, but only for our more tech-savvy patients. We measured increased patient satisfaction and reduced return visits in patients that actually engaged with this process. But older and more socially vulnerable patients often opted out. And in retrospect, that was the blind spot of this project, an absence of user-centered design. We included the frontline team, but we failed to engage the patients. So I've decided to start again. And in a recently funded grant, co-led by 2 of my outstanding junior faculty mentees, we're inviting a diverse group of patients to help collaboratively redesign the ED discharge process. And we've specifically included socially vulnerable, elderly, and patients without English literacy to help us build out a more inclusive discharge process, which may involve technology, but it will be driven by their needs rather than our perception of their needs. And there'll be more to follow on that project for the next 6 to 12 months. Okay, so I'm going to pivot to the COVID era because I think our journey as a learning health system was greatly accelerated during this time. And there are a few insights, the positive and the challenges, that I'd like to share with this audience. March 14th, 2020 marked the first COVID death in New York City. For context, I went to a movie the week before and no one was wearing a mask except me. Only 10 days later from that event, our organization's early models predicted total saturation of inpatient resources, specifically ventilators, by early to mid-April. In the setting of this unprecedented health crisis, by March the 30th, the floating US Navy hospital arrived at Manhattan's docks. And 4 days after that, the US Army stood up a disaster relief hospital in our city's largest conference center. So to try and address this rapidly progressive crisis, but a crisis of the unknown, we, of course, prioritized turning on the lights and developed ED dashboards to help us inform real-time iterative changes to our care model based on number of patients diagnosed positive with COVID, being tested for COVID, discharged home, admitted for COVID. For example, when the frequency of daily critically ill COVID patients in the emergency room increased past our predetermined threshold, we immediately converted one of the emergency room areas into an ICU COVID unit. So tracking the right data closely had enabled us to plan ahead with the design and staffing model of this ED ICU and turn it on straight away. And so what's the difference from prior dashboard development and our COVID dashboard? Nothing in its architecture. It was more that we were able to stand it up in 10 days rather than 10 weeks. And that was largely due to cross-department collaboration and, of course, prioritization. In the 3 to 4 years prior to COVID, our department had developed substantial telehealth knowledge and infrastructure. We built a virtual urgent care system and remote telemedicine consult services for our smaller hospitals, which leveraged the specialists at Cornell remotely. During COVID, we deployed the same technology inside the ED so that providers could interact with patients frequently, while simultaneously reducing direct patient-provider contact. And this was critical early on due to PPE shortages in the US, which created a need to provide new levels of safety for our care teams, but without reducing their ability to reassess patients who were potentially unstable. And what we found from Cornell's early COVID data, and my ICU and cardiology colleagues went on to publish these findings in the New England Journal in June of that year, was that almost a third of patients who ultimately required mechanical ventilation while hospitalized did not even need supplemental oxygen at time of initial ED evaluation. And so this presented a distinct problem for emergency medicine care. If some patients deteriorate late, how do we know who to discharge safely? And at a time when inpatient units and our ICUs were getting filled to capacity, it was critical to understand who was stable enough to go home. So we created a third arm to our evolving ED COVID clinical evaluation pathway that's on the screen now. And this third arm in orange was designed to reduce inpatient admissions, but simultaneously mitigate the risk of discharging patients who could later deteriorate. And I'm pleased to say that actually a substantial portion of that pathway, which was designed by a group of 8 leaders across the enterprise, went on to inform national guidelines by the American College of Emergency Physicians. But it's important to tell another part of this story. And this is me around that same time taking one of my feedback walks with 2 of our frontline providers. It became clear during those feedback walks that the evaluation pathway that we designed was pretty tough to use for the busy providers. They're double gloved, they're anxious, they're trying to navigate this really busy 2-page process map on their workstations. And we put a lot of effort into it, but I've learned over the years how critical it is when you're building out new interventions or processes to be constantly rounding with end users to receive feedback on the design. Usability is everything. So, I took the feedback and partnered with the MD Calc team and moved the tool into a more usable electronic app format that people could look up on their smartphones, almost basic clinical decision support. And the results were a real success. We clocked 15,000 hits in the first 6 months. So lessons learned there too. So going back to this moderate risk COVID workflow, so we again leveraged this pre-existing telehealth knowledge and infrastructure we had to rapidly develop a remote patient monitoring program. That was something we hadn't done before. We sent these moderate risk patients home from the ED with a pulse oximeter and portable oxygen tanks. And once home, we followed them really closely with using our nurse practitioners with daily telemedicine follow-up encounters, including monitoring of their vital signs, a virtual exam, coaching the patients on self-monitoring and clarifications on return instructions. And we launched that program within 1 week of initial conception, again, in the context of predictions that we would run out of ventilators and deaths would occur due to health capacity constraint rather than the severity of COVID. And I believe we were successful. We diverted just under 700 hospital admissions at a time when available ventilators in our organization were close to single digits. Our cohort showed dramatically lower mortality compared to the patients we admitted during the same time period, 1.9% compared to 10 to 21% in New York City at the time. So our aim, I think, was relatively true, but we were far from perfect. We lost 3% of that cohort to follow-up. Some patients refused to return to the ED when we identified worrying signs and symptoms. And we also discovered along the way that there are significant barriers to many patients, vulnerable patients, engaging with video-based telehealth encounters. We had to do a lot of it via phone. So I think we did a good job of demonstrating the potential power of telemedicine and remote patient monitoring as a combination for hospital-at-home concepts of the future. But I also learned that we got to do a lot of future investment in infrastructure and strategies and better understanding of patient engagement and resources that would be key for this almost inevitable future of hospital at home, certainly in the US. So on reflection, our successes during COVID felt like a large step forward in some of the basic principles of the learning health system and indeed ambidexterity. Our efforts were driven almost exclusively by our immediate need to iterate our care models for optimal patient outcomes in a disease we didn't know anything about. And this mission was heavily reliant on the 2 cornerstones: standing up informatics, cross-disciplinary partnerships, and collaborative culture. And the innovations we made were in the setting of calculated risks. And the rapid cycle iterations were largely based on 2 things: clinician feedback and the evolving knowledge on COVID from the data we were able to generate. But I think what we didn't have time to do sufficiently in the moment And what I've done now, or in retrospect, was reflect on the areas where we were unable to manifest the learning health system, and why. I was involved in work predicting acute renal failure in COVID patients, and it was developed too late to inform the first wave. In collaboration with laboratory medicine and population health sciences in our institution, we developed a machine learning model that utilized basic lab results to accurately predict acute COVID infection. And this was valuable at that moment during the initial COVID test shortages. But we didn't yet have the infrastructure to rapidly implement this model into the EHR, at least not in time to be of use, because COVID tests rapidly scaled across the US and shortages went away, and this great work became obsolete. And similarly, the work I was perhaps most frustrated by in retrospect was our regression model-based phenotyping of COVID patients admitted to the hospital. And I worked with an outstanding team, including Sampreet Banerjee and the great Monica Safford. And the model identified 3 phenotypes of patients. One of those phenotypes appeared well in the first 24 hours of admission, but deteriorated later on in their hospital stay. Again, we didn't have the infrastructure to rapidly implement this model as EHR-based clinical decision support. Again, at least not in time to be of use. But we also hadn't thought through the complex post-implementation decisions around revalidation or data flow architecture for continuous learning, and so on. Many of you probably know Escobar's outstanding work at California's Kaiser Permanente. And that model proves that if you can identify patients at risk of clinical deterioration early, you can improve outcome and save lives. So this missed opportunity was pretty tough for me to swallow. So after the first COVID wave died down in the summer of 2020, I was able to take some respite at my happy place, the ocean. And in between surfing, I began to think about how I could help break through the sort of learning health system glass ceiling I felt we were experiencing as an organization. And I knew I wanted to implement machine learning models into practice as clinical decision support. I knew that was the next step. But I also wanted to make sure that work would be grounded in a priority quality target to ensure that this innovation was on track to improve patient outcomes. So just to take a step back, a number of single-site studies examining RVA, which are patients who were discharged home on their initial ED visit, but rapidly bounced back to the ED and are sick enough on that return visit to warrant hospital admission, suggested that this event might be an outcome by which to evaluate the quality of emergency medicine care. That work was done in the 2010s, but Sabatini et al.'s work in 2016, using a large data set and published in JAMA, suggested that, okay, well, maybe some of these patients could have been admitted on their first ED visit, ideally, that delaying inpatient care by up to 7 days did not significantly affect their outcomes. But Sabatini's cohort had a median age of 55, and to me and my team, these findings didn't necessarily track with other research demonstrating that delayed diagnosis and treatment in the elderly, particularly in syndromes such as delirium and sepsis, greatly increased mortality. Again, just in the elderly. So we leveraged a national data set to perform a modified version of Sabatini's high-quality analysis. My team looked specifically at older adults, though. And as we suspected, the subgroup of older adults that bounced back to the ED within just 72 hours and are sick enough to be admitted on that return visit have significantly worse outcomes than even patients determined sick enough to be admitted on their first visit. And this to me felt like an opportunity worth exploring. Like, who are these patients and why do really good, experienced emergency physicians initially perceive them as well enough to go home? And particularly in the elderly, what subtle disease presentations and unexpected disease trajectories and ultimately failed outpatient management plans are behind this data story? And perhaps most importantly is, are these outcomes modifiable? And these findings really engage some of our frontline team. You know, most of the patients we see in emergency medicine are discharged. And unlike, say, a plastic surgeon who reviews all of their post-op patients or a cardiologist who has the privilege of following their patients for years, there's an inherent gap in ED physicians' knowledge about the outcomes of the patients they discharge home, the vast majority of them. In that sense, you can consider emergency physicians uniquely challenged to calibrate and develop their practice patterns over the life of their career when they have little knowledge of the outcomes of the patients they discharge home. So we incorporated ED return visits into the clinician feedback dashboard. And this allowed providers to review their return visits non-judgmentally. And we leveraged data across our entire health system to uncover when patients bounce back. And providers were able to see their aggregate data, but also drill down and review and learn from individual cases. On this screenshot, you can see that we also plotted it against short stay admissions, which allowed providers to understand, are they conservative or liberal, and the downside and the pros and the cons to a conservative or liberal practice. Again, the goal here was just non-punitive, transparent review of data. And this dynamic tool, I feel, addressed the three key principles of bringing learning health data to the front line. It's transparent, it allows for accountability, but it also presents data in a format providers can learn from. Okay, so back to the machine learning. Now we've learned a bit about RVA. So both emergency medicine and geriatric US national bodies have recommended that older adults come to the ED receive formal risk screening. And the current risk screening tools on the market, like the ISAR and the TRST, they're heuristically developed manual questionnaires. And by virtue of being questionnaires, they rely on the patient being cognitively intact and being able to answer these 5 to 6 questions. And they were actually designed to detect adverse events months after the patient was discharged from the ED. And, you know, in subsequent studies, unfortunately, their precision has not been generalizable. And so it's perhaps no surprise that the adoption of these tools in a chaotic ED environment where providers are rushing around, multitasking, and frequently interrupted has been limited. And what I began to see was an EHR that's rich in multidimensional variables for each patient, and the potential of machine learning to utilize that structured data to try and reflect the complex multidimensional risk of older adults in the ED, and perhaps risk that the bedside ED provider was missing in some cases. And I wanted to explore if a machine learning model could accurately predict the risk for return visit admissions. And so I've been lucky enough to form a partnership with an outstanding machine learning expert, Yie Zhang. I think it's really important to emphasize how much the collaboration is between pure scientists, clinician scientists, and pure clinicians is. I don't think you can become an excellent learning health system without full collaboration across that spectrum of science and clinicians. And we worked together on various projects over the past 4 years and realized maybe within the first year that for our collaborations to really yield true excellence would need to become plurilingual. And by that, I reflected that I needed to deepen my understanding of machine learning. You know, the infrastructure that would be needed for, say, to support models using structured and unstructured data, and evaluating model performance and approaches to missing data, for example. And so I spent a lot of time learning from the implementation challenges of similar teams that were maybe a step ahead of us at other organizations. But the reverse is also true, in that I invested a substantial amount of time in exposing Yie, who's not a physician, to the language of clinical medicine. She shadowed me during multiple shifts to observe the care model, how I interacted with both the EHR and with patients. And I think one of the things she took back was the profound differences between the patient in front of us and the EHR's representation of the patient using data. You know, we attended each other's conferences and learned to understand the challenges of each other's worlds. And in the process, you know, we learned when to compromise and when to push for new solutions. And I think that was a really important journey. And so that partnership has led to the GEMRA team, and our work is to develop a machine learning model that predicts geriatric return visit admissions. And Yie's model is the primary success story to date. Her team developed this novel framework. It's deep significance clustering, DICE is what it's been called. Now, Yie's DICE is a self-supervised learning framework that bridges the gap between unsupervised learning algorithms, clustering algorithms. The advantage of the unsupervised is identifying clinically meaningful subgroups, and the supervised risk prediction algorithms and their advantages of accurate risk prediction. So this is an end-to-end risk stratifying predictive clustering algorithm, so bridging the gap between between unsupervised and supervised risk prediction. The patients within each subgroup are intended to have similar levels of risk and outcome, as well as similar clinical needs. And the purpose of that is to ensure that when the ML model becomes clinical decision support, it has clinically meaningful output. And we chose to leverage all the clinically relevant structured EHR data that would be available to us during an ED visit as model input from the ED encounter itself. So the vital signs, the delta changes in vital signs, what tests were ordered for the patients, those test results and delta changes from prior test results, what therapeutics were given, as well as the patient's socio-demographic data, their chronic conditions, and prior healthcare utilization. The results of our preliminary work have been pretty encouraging. We have an AUC of 0.87 in our preliminary work, and that was derived from training the model on one of our hospitals' retrospective data, 2017 to 19 data, and then performing retrospective validation from data at our other hospital. And the advantage there is the two hospitals have dramatically different patient populations. Same EHR, same providers, but different patient populations. And to date, GEMRA's DICE model has outperformed a published conventional heuristic RVA risk score, the only one that's been published, and then also outperformed traditional machine learning regression models. So another more simplified way to describe this work's foundational hypothesis in non-machine learning terms, in clinician terms, is the belief that the majority of RVA events by the end of the initial ED encounter will produce a data prodrome in the EHR, smoke, if you will, before the fire, and that smoke will be consistently accurate in predicting RVAs across different patient presentations, patient populations, EHRs, and provider practices and communities. And we've used slides and concepts like this, which certainly don't do EA's DICE model justice, but they do help build foundational knowledge and trust in machine learning models within our organization. And they also ensured that New York Presbyterian's insurance company was on board to fund our preliminary work. So they can be very helpful. I initially told EA, we need graphics, we need visuals. We need to really explain to people who are not in our lane what we're trying to do. We need to kind of show them under the hood, but also build trust in the process. And she initially offered me this image, which in fairness to her, is very much under the hood, but did not perhaps engage the uninitiated in our project. So back to compromise, we eventually arrived at a compromise of these graphics, which describe with perhaps some cartoon-like simplicity some of the more basic concepts of how machine learning models use vast and complex EHR data to create output to support clinical decision-making. And again, the goal was to develop transparency and trust in the basic concepts of machine learning that are maybe not intuitive to many frontline teams or hospital leaders now in 2023. And we wanted to do that before we asked them to trust GEMRA's output. So GEMRA's preliminary performance, and I think our ability to tell a compelling story about predictive analytics in older adults and the value of the RVA outcome, facilitated federal funding to further develop GEMRA in a 5-year mixed method study. And I'll just review the study. Our goals in aim 1 are to minimize bias and fine-tune GEMRA's precision with further retrospective data sets from 5 different hospitals. We then moved to further retrospective external validation at geographically disparate sites. And part of those journeys is to debias the model to fine-tune to precision. We also plan to evaluate GEMRA performance across diagnostic categories. For example, how does it perform in sepsis? And identifying the degree of model error, as well as the most impactful predictors for model performance. One approach is we may choose to prune the model from currently 478 variables down to 50 variables to see how much AUC we lose in that process. We'll then plan to perform a prospective validation comparing head-to-head GEMRA against physician judgment in real time, as well as the conventional heuristic risk scoring tools that I mentioned. And finally, using conventional participatory design methodology and engaging frontline staff as well as key leadership stakeholders, we aim to develop usable EHR integrated clinical decision support, but also simultaneously design accompanying clinical workflows that will support the CDS and make the most of it. And then we want to further test the utility of the beta model with a pilot implementation and generate a second round of end user feedback for final iterations. The goal of this study is really to lay the table of GEMRA for a randomized control trial. So as we look forward to the future of GEMRA, and I imagine other research teams with similar models, being developed across the world, I wanted to share a quote from Escobar, the lead researcher I mentioned for the Kaiser Permeante deterioration model. He gave a grand rounds and he said, for every dollar spent on model development, it'll cost $10 to $15 to implement. And so my question back to the universe, I suppose, is how much then in infrastructure to support continuous learning, cyclical validation, and regulation compliance? Having seen EPIC sepsis model fail during COVID, we have some interesting plans to test the generalizability of GEMRA against distributional shift. If you remember, I said we were going to train the model on 2017 to 19 data. We're going to save the 2020 and 21 data sets to test RVA prediction in the setting of the massive distributional shift of the COVID pandemic. How's it going to perform with the unknown, with new patients behaving in new ways with new diseases? And based on GEMRA's performance against those kind of tests, as well as the generalizability at other geographical sites, we'll have to come to some difficult decisions about what we're trying to do next. Are we trying to create GEMRA bottled olive oil that's good for every EHR, every community, and every physician practice? Or are we trying to distribute GEMRA olive trees for local sites to retrain the model and develop their own olive oil from? This is an image I stole from Wendy's blog. It's an art installation called Fragments by Wade Cram. And I think it also offers a visual analogy to the potential endpoint of the GEMRA project. It's possible that GEMRA, using contemporary machine learning techniques and current EHR data, predicts RVAs in certain disease groups really well, and in other disease groups, not so well. And while on the surface, that may seem like a disappointment or a failure, I disagree. I think that potential journey, if it happens, it will help us learn even more about what's behind these geriatric RVA events and outcomes. We may end up pivoting to focus GEMRA on detecting one of the specific real killers in older adults, such as delirium or sepsis. And so my final point in this presentation is I continue to try to embody the learning leader and prioritize intellectual curiosity over sometimes the temptation to distort the reality, the data in front of you for easy wins, even when it involves a federal grant for whom I am primary investigator. So I think a key take home of the learning leader is intellectual curiosity over easy wins. So it's a lot of slides, a lot of talking. I'll close here. This is my email address if anybody wants to email me with questions they don't feel like discussing in the final 15 minutes. Wendy and team, thank you again for inviting me, and maybe I'll stop.